Hello everyone, my name is Vadim Koshkin. I'm here with GU Oncology now, and here with me I have Dr. Seth Lerner. He needs no introduction, but I'll let him maybe quickly introduce himself.
I'm Seth Lerner. I'm a urologic oncologist at Baylor College of Medicine in Houston, Texas, and I've been involved in the SWOG GU committee for 30 years, and I'm the PI of SWOG S1011, which we'll be presenting tomorrow.
Yeah, so today we're talking about the SWOG S1011 trial. Maybe to start out, Dr. Lerner, if you can describe what the current standard of care is for surgical standard of care for muscle-invasive bladder cancer.
Right. So the radical cystectomy, which always incorporates a bilateral pelvic lymphadenectomy, that was established decades ago, and so based upon work that was published really and driven by Don Skinner from USC, taught us all, and then we taught our students and residents and fellows that node dissection should really be what we call an extended pelvic and iliac node dissection, at least up to the aortic bifurcation, so common iliac and then external, internal, and obturator lymph nodes.
And what question was this trial designed to address?
Right, so at the time that we designed the trial, really probably started in earnest around 2010, there wasn't any high-level evidence to really support what we were doing. Other than, a standard bilateral should be part and parcel of the operation. So we designed the trial to ask and answer the question, would an extended node dissection in curable muscle-invasive urothelial cancer help people live longer, disease-free survival? So that was the fundamental question that we were addressing in the trial.
Great. And maybe to go over quickly the trial design. So how were the patients randomized?
Well, yeah, so this is actually a limited institution study. 36 surgeons, 27 centers, surgeons all had to be credentialed, meaning they had to reach a certain bar of cystectomies per year. The hospital had to do that. I think it was 50 per year for 3 years. So these were highly curated, if you will, really experts in academic health centers. And then the trial, patients were registered based upon, the eligibility, and then there was an intraoperative randomization to extended plus standard versus standard alone after a negative exploration in the extended template. So these theoretically were patients who were, again, curable, and if they had positive nodes, it'd be confined to or at least grossly positive, confined to the pelvis.
And what were the primary endpoints?
Primary endpoint was disease-free survival. We based it around a 3-year endpoint, and then overall survival was a secondary endpoint, and we could continue follow-up out to 6 years, which is what we'll be reporting here.
And what did the trial show? What were the main results?
The trial showed that there was no benefit to performing an extended node dissection in this patient population. The curves were essentially overlapping for both DFS and OS.
Mm-hmm. So no benefit with extended lymph node dissection. Was there excess toxicity?
So there was some modest excess toxicity in the extended arm, driven a lot by urinary tract infections, grade 3 anemia, lower rate of sepsis, but a little higher in the extended arm, and then mortality rate, and this is independent of whether there was a perceived relationship to the surgery or the node dissection, was about 2.5 times in the extended arm, but still well within sort of what I think most of us feel are accepted mortality rates at 90 days.
Mm-hmm. And I believe in the extended lymph node dissection group, there was more N2 and N3 disease, so maybe more extensive disease. Do you think that affected things in any way?
Well, so actually what you would expect to see is N3 disease, which by definition is common iliac lymph nodes. You should really only detect that in the extended template. There were a handful of patients who were randomized to standard that did get an extended, but N1, N2, which is confined to the true pelvis, was similar in both groups.
Mm-hmm. So from the results of this trial, what are your main conclusions?
Very simple. We've clearly established that a bilateral standard pelvic node dissection should be performed in every patient undergoing cystectomy for cure. And there's really no need in that patient population to take the node dissection any further, unless you see something intraoperatively that's concerning, Certainly we do frozen sections often, but that really now has solidified the standard of care. There was a second trial that was done, actually has been reported out from Germany, led by Jürgen Geschwend, that essentially showed the same thing. So now you've got two trials showing really convincing level 1 evidence that just a standard node dissection should be the standard of care.
Yeah. Well, this is very important data, and these trials are very challenging to do. So congratulations again on completing this study and presenting this data here.
Yeah, thanks so much. Very much a group effort. Appreciate the time.
Yeah.
Thanks.